welcome to another episode of Warrior1Spine. I don't have a long intro today, but I just wanted to start off by just thanking you guys for your engagement. It's been amazing to see just how the views and the participation and engagement during the calls, but also post calls on the Warrior1Spine YouTube channel. And we're going to ask for your help too, is just continue to really download this stuff to warriors, to spinal warriors, spinal reconstructive warriors, or even the younger generation is really important to get engaged, because we want more and more reconstruction and spinal correction happening in our profession. And I mean, this is huge for them. I wish we would have had this when we were going through it, because we had to really search high and low and far and deep to try to get this stuff. Actually, a lot of the research wasn't available back then. So yeah, just make sure the students get engaged. I wanted to also take this opportunity to just thank Pascal for this series. It's been amazing. We're going to have another amazing episode today with some of the top postural correction exercises in spinal reconstruction. And one more thing, we were just chatting before we started here, is that we're about to kind of set up the next series in terms of topics. So if you guys could just take a moment, like whether it's during the call today, just send a quick email, or right after the call, and please do it today, because, you know, as soon as you get off the call, life happens. So if you guys can just email us at info@warriorcoaching.global. So that's info@warriorcoaching.global, and just give us some one-liners in terms of what you guys would like to see as topics for our next series over the next 4, 6, 8 episodes. That'd be really great for us to be able to direct this thing in terms of really meeting your needs. Yeah, and that's about it. Yuri, Pascal, you guys can take it away. You guys have a great call.
Yeah, I'm all good.
Awesome. Well, thank you guys. And I guess it's reciprocal. I'd like to thank you guys for having me on. You know, I absolutely love doing this. I love the engagement that the Warrior Docs have. I love the fact that you guys are committed and loyal to not only improving the profession, but getting better results for your patients in terms of corrective chiropractic. So thank you for having me. And please do send the topics to Dr. Zed and Dr. Yuri, because it does help us. It helps me to know what can we teach, where do you want to learn, and where do you want more information. So today we're going to be talking about my 4 favorite postural exercises. And I think it's going to be a little bit more of a laid back webinar today, because it's not as technical. It's going to be a little bit more simple, a little bit more fun. I've got some videos embedded into there. And so it's a little bit of a hands-on practical how-to. So we're going to talk about my 4 favorite exercises. Just give me a thumbs up. You can see my screen okay? Perfect. All right, so let's bring this full screen. So my 4 favorite exercises. There's not one patient that comes through my office that does not get at least one of these 4 exercises. Every single patient in our office does exercise, adjustments, and traction. The exercises do not replace the adjustments. The exercises do not replace the traction. The 3 have to happen together in concert for our patients to get the best results possible. So we've talked over and over about traction, right? The dental rolls and the posture regainers, the lumbar dental rolls, the thoracic rolls. We've talked about everything that you can do in terms of traction for your patients at home. The adjustment, that's the magic. Everybody has a different art to how they do the adjustments in office. And you keep doing that how you want to do that. I'm here to help you guys with the exercises and the traction. So today we're going to talk about the exercises that we give our patients to improve the results that they're going to get. So the 4 exercises that I love, and like I said, every patient gets at least one of these in addition to their dental roll. And sometimes they'll get 2 or 3 different exercises. It depends on the case, but everybody gets at least one of these, and they all have different applications. So first and foremost, the Pro-Lordotic neck exerciser. We've covered this on previous webinars, but we're going to look at it again today. And I'm going to add sort of a component to that. You see here in parentheses, it says with the flip movement. I'm not sure if any of you have heard of what I've talked about in the past. Is called the Fedorchuk exercise, right? He's kind of coined it now, the Fedorchuk lordosis inducing postural exercise. And it is really good to add this when someone is doing a pro-lordotic, when they have a specific straight neck without much forward head posture. When they add this, the corrective results go through the roof, okay? So the Pro-Lordotic neck exerciser is given to patients who have anterior head translation and loss of lordosis. Titanic. Last webinar was on the effects of the effects of COVID on posture. We talked about using the posture regainer. Well, the exercise that I was showing you guys up against the wall was called the Titanic. So today I'm going to play a video of that so we can go through it slowly and go through it so that people can understand exactly how to use that exercise. That exercise is a triple combination. Okay, so when someone starts to have that postural breakdown, they get anterior head shifting, right? They get posterior thorax shifting, and their pelvis shifts anterior. So like this triple combination, this is the best exercise to reduce and correct that. Prone thoracic extension. So this is one where the patient lays on their stomach, and this exercise is for when patients have rounding in their shoulders, but they don't shift backwards. As a matter of fact, it's almost like a rocket ship posture. You know, when you look at their posture from side profile, they're almost on the balls of their feet, maybe on their toes. It looks like they're about to take off for like a ski jump, like big ski jumping. And so these patients, you know, they need not the Titanic, but we want them doing what's called the prone thoracic extension. And then maybe my favorite overall postural exercise that I do myself, you know, probably 100 reps of wall angel every single week. Not only is it great for correcting forward head posture and postural kyphosis and internal rotation of the shoulders, I use it not just for correction, it's like my maintenance exercise. If you think of us as chiropractors, there's not one chiropractor who's not hunched over his table, round his shoulders, head forward. You know, you're adjusting people all day long. You have to be doing these exercises yourself. You also need to be the leader in showing your patients that you're doing these yourselves. And so I use the wall angel on almost every single patient, not only as a corrective exercise, even if they've got perfect posture, it's a fantastic maintenance exercise for upper cervical health, upper shoulder health, and decreasing thoracic kyphosis. So let's get into it. Okay, the Pro-Lordotic neck exerciser. So again, the indications for using a Pro-Lordotic would be the same as using a Dental. You see loss of cervical curve with anterior head translation, right? So here's a perfect example. You see here, the green line should be where the patient would be ideally, and they are the red line. So they've got loss of curve with anterior head translation. And so we're going to go to showing you guys how to do, whoops, let's go back up here. I'm going to escape this, and we're going to go here. And we can all still see my screen if I go to this video. Did you guys lose my screen?
No, it's good.
It's good. Thank you. All right. So here's a video of Dr. Dan doing the Pro-Lordotic neck exercise. So we have the band, right? We have the patient push their arms out to the side. Sorry, let me get the volume down on this. We don't need the volume. I'm going to talk through it. So the arms come forward, and the neck exerciser.
Sorry, we don't see the video, Pascal.
You don't see the video. Okay. Let me pause this, and let's go to screen share. Let's go to here. I think you should be able to see it now.
Yes.
We can see it?
Yeah.
Okay, so let's rewind that a little bit. Okay, so we have the patient grab this band, right? They put the band around their neck, and they're holding it as if they're holding onto a pull-up bar. So we have the patient extend the band out, they lock it out. Their arms come forward just below horizon or level to horizon. Now that's creating the fulcrum for them, right? And so what they're gonna do is they lift their chin and drive their head back. Okay, they contract it for 10 seconds, and then they relax, and they're going to repeat the exercise over. Okay, so this is just the standard procedure. Okay, so when a patient has forward head posture, loss of curve, they use this. We have our patients do this in the office, and I'll explain why in a minute. But you'll notice Dr. Dan lifts his chin, and then he drives his head backwards. So that is two movements. That's two parts of the flip. There's one part that he's not doing there. That's assuming that the patient already has a lot of forward head posture. So let me go through this back to here, and I'll explain what I mean by that. So new share, let's go back to my presentation. So if the patient had a lot of forward head posture like you see on this screen. So the patient on the left here has got 43 mils of anterior head translation, okay? They've got already quite a bit of curve down here in the neck. This patient can do exactly what you saw in that video. They lock out the band. All this patient would need to do is lift their chin, drive their head backwards, and they're going to get great correction. And so this is the young lady here. I said, let me take a stress x-ray of you doing this. I do a lot of stress x-rays on patients. I'm x-ray happy, if you will. And so she does the Pro-Lordotic neck exercise. You can see it wrapped around her neck right there. And seconds later, she does the exercise. She goes from 9 degrees of lordosis to 29. Beautiful. She goes from 43 millimeters of anterior head translation down to 13. It's a beautiful correction. It would not be this nice if she did not have this level of anterior head translation. What do I mean by that? Well, let's go to the next slide. So here's another young lady. So this young lady here, her neck is actually very flat, right? She doesn't have a ton of head posture. It's about 20 millimeters forward. And she actually has a kyphosis. So if this young lady did the Pro-Lordotic neck exercise or just bringing her neck back, she might get a few degrees of correction, but it would not be nearly as nice as what I showed you on that previous stress film. So when I see necks that are very flat, very straight like this, without much anterior head translation, I make them do something called the flip exercise. Okay, so let's just compare x-rays. Here's her neutral. This is a young lady who came in about 2 weeks ago. So I have her drive her head backwards just to see what her x-ray looks like on a stress film. Okay, she drives her head backwards, just tucking her chin. This is what it looks like. Terrible, right? Nothing special. I have her do what's called the flip exercise. And this is her seconds later, right? So this is day one. This is, or I guess I should say, this is doctor's report. And this is like her first visit in office. I'm doing stress films. Look at how nice that lordosis is by doing the flip exercise. Now, if I had the Pro-Lordotic pulling right here forward as well, we'd get even more lordosis at that 4-5 segment. It would be beautiful. So on those hard necks to correct that are flat, that are kyphotic, you want to do a Pro-Lordotic, but you want to do it in combination with this exercise. So let me get off my pen here, and then I'm going to just move this. And so let's play this video. So it's head forward, okay? So that's the difference. People that don't have much forward head posture, you want them to actually drive their head forward first. So imagine if I had the Pro-Lordotic, I'd bring my arms forward, but I let my head maximally translate anterior. It's almost counterintuitive, but this allows the vertebrae to stack properly. Then I lift my chin, then I bring my head back and I hold it in that position. Whoops, let's go back to that. So one more time, if the patient has forward head posture that looks like this on the left, not much, okay? You need them to drive their head forward first. So this is the flip exercise, right? Forward head, chin up, chin back. They hold with the Pro-Lordotic in that position. And those tough necks that are hard to correct, you will see your corrective results go through the roof. So if the patient has a ton of forward head posture, all they got to do is lift their chin and drive their head back. If they have a flat neck like this and moderate forward head posture, let's use a cutoff of 30 mils or less. So if there's 30 millimeters or less on x-ray of forward head posture, I would have them do the Pro-Lordotic, but in that fashion. Let them drive their head forward first, chin up, drive their head back, and you will see wonderful corrective results, okay? Like all corrective exercises, I have my patients do 2 to 3 sets of 10. Minimum 2 sets of 10, so they're doing 20 reps with a 10-second contraction, so a 10-second hold. So once they've gone through that sequence, they're at end range. I have them count to 10, relax, repeat 20 times, or 2 sets of 10. I have my patients do this in office. Can you have your patients do this at home? Sure. I send all of my patients home with their dental rolls so they can do traction at home. I send them home with send them some exercises to do at home, but this one I want them to do in office. Why? Because when they're coming 3 times a week, I want to keep them accountable to at least doing the minimal amount that they can do. I send them home with a Pro-Lordotic and a dental roll. Where's their compliance? How can I guarantee they're doing anything? If I tell them they have to do it 3 times a week in office, either pre or post adjustment, however you want to structure it for your volume and your office flow, now I can see the patient doing it. I can also ensure that they're doing it correctly. And if it's a patient who just comes in, gets adjusted, and sneaks out of the office without doing their exercises, well, when it comes time to review their x-rays or review their posture and their results suck, or they don't have very good correction, well, you know, there's no lying. They can't lie to me and say, oh yeah, doc, I'm doing my stuff all the time. It's very clear. You ask them, hey, have you been doing your exercises? No, as a matter of fact, doc, you know, I've been sneaking out of here without doing my exercise. So I like having patients do this in office to increase accountability, but also so that I can watch them doing it. And then the other thing that I love is, now that hopefully COVID keeps us settled down, is people do this in the office. So it keeps them in the office longer. There's more people in the office. The environment's buzzing and it's just high energy. So I've chosen to do them in office. You could choose to send people home with it if you'd like, but in office keeps them accountable. Okay. The effects of COVID on posture. We talked about this. We even showed you these two cases last time. So when someone's posture starts to break down, and I see this specific triple combination, I mentioned it earlier. I'm going to bring out my pen so I can draw it. He's more obvious, this one, but this guy's a little more subtle. So let's go through this. The head forward is obviously not subtle at all. So if I look at ear relative to AC joint, his head has gone forward. Everybody can see that clear as day. The one that's a little bit harder to see, and this dot should have been actually right here. So this dot is supposed to be the greater trochanter. So his AC joint is definitely posterior to his greater trochanter when I'm looking at him in side profile. So that means his rib cage has shifted backwards, and we can clearly see it here on x-ray. The red line is posterior. We're behind the green reference line. If I dropped this line vertically straight down, right? If that was, you're hallucinating that is a nice straight line. If I look at that compared to the lateral malleolus on the ankle, his pelvis is anterior. So it's a triple combination posture. Here it's very obvious. You can see his pelvis is forward, his shoulders are back, the head is forward. So in cases like this, I have people do the Titanic. I make them do it with a posture regainer. They could use a yoga block if you're not giving a posture regainer. If you want them to do this in office, get a bunch of cheap $10 yoga blocks, keep them in the office. But this is that triple combination posture. So I have them stand with their feet off the wall. Okay. Now we can clearly see that the pelvis, as you push the pelvis back, posture 1 has been corrected. My pelvis is posterior to my ankle. As I push my pelvis back, it drives my rib cage forward. Now my shoulder joint is anterior to my pelvis, right? So posture 2 is corrected. 3, it's the chin up, and it's like doing that lordosis exercise that we just showed you. They go chin up and they drive their head back to correct neck curve and induce lordosis. So I don't want them just straight drawing their chin back, because that's going to do nothing to increase their neck curve. It's like doing that flip exercise, right? They can even start by pushing their head forward. They go chin up, and then the face goes down and back. So let's watch an active video of me doing this, or maybe it's Dr. Dan. Let's see. Let's get the volume off of here. And now all of these exercises that I'm showing you are all on my YouTube page. So I've put these all up for my patients or for other doctors to go back and watch. So if you have any questions, go back and watch it on the YouTube page as well. Okay, so let's just fast forward to this. So here I'm trying to exaggerate that posture, right? Rounded shoulders, shoulders are backwards, head is forward, pelvis is forward. So this exercise is that triple combination to undo that. Okay, and so you see I'm holding a yoga block. I put the yoga block behind my shoulders. And as we mentioned, I push the pelvis back. And then from there, we're going to lift the chin, and I'm going to draw my chin back. And I always go palms up and out, right? Patients hold that position just like that, right? So it goes pelvis back, palms open, externally rotating again, because everybody's always forward and internally rotated. So the palms externally rotate. I drive the arms back. I lift the chin up, drive the head back. And like all my other postural exercises, I have patients count to 10, relax, and then repeat 20 times, right? Or 2 sets of 10. If they're keeners, yes. Can they do this all day long? Sure. They could do 50, 60, 70 reps a day. It's not going to hurt them. So this is, again, for that posture that we just showed you. Anybody that gets a posture regainer should also get this exercise, or anybody that you see that type of posterior shift, rounding in the shoulders, head goes forward. This is a great corrective exercise for them to do. Prone thoracic extension. All right, so now let's say if I looked at my patient and their shoulders don't go behind their pelvis, but their shoulders go anterior. So here's a case where I wouldn't want to give this guy the Titanic, because his rib cage is already forward of his pelvis. I hope that makes sense to people. So if he's doing the Titanic, he's pushing his pelvis backwards. We're just making this go further forward than it already is. So again, let's look at the relationship here. His head, the ear canal relative to the AC joint, his head has gone forward. So that would be one of the indicators. But when I come down and I look at his AC relative to his greater trochanter, I can see that it's forward and not backwards, right? So here's that posture I was telling you about, where he's not a drastic case of it, but everything is leaning forward. So what I want to do in his case is called prone thoracic extension. I actually want to bring the rib cage and the head back relative to his greater trochanter. If you look at his x-ray, here's an example of it, right? His T1 has shifted forward of his S1. If I had his lateral cervical, you'd see that his C1 is forward of T1. So everything is forward. So what we do then is the prone thoracic extension. Let's get the volume off. Okay. And let's forward to this. So here's a much more drastic example. And you might see this in an older patient who has a very stooped posture. If I use my pen one more time to highlight that, look at the dot on my pants there. That's roughly greater trochanter. This is a perfect example because they'd also be kyphotic. They'd have extra rounding. The shoulder, the AC joint, if I was to drop that plumb line down, it has shifted anterior to my pelvis, and my head, my ear canal relative to my shoulder, it is also anterior of my shoulder. So it's forward with rounding in the shoulders. That's the classic textbook case where I want them to do this exercise on the ground. So let's erase ink, play. Let's find it. Okay, so they lay on the ground, right? I always have my patients maintain contact with their feet and their quads. If you don't specifically instruct them to do that, almost everybody will want to lift the feet off the ground. If you lift the feet off the ground and you start having people kind of squeeze their bum and their quads too much, they're actually going to engage a ton of lumbar, and they're just going to be, it's going to be more of a lumbar hyperextension exercise than it will be targeting the upper thoracic and neck muscles. So I tell them quads stay on the ground, feet have to stay on the ground, and I instruct them that I want the contraction to happen specifically almost from T12 up. So I tell them I want them to feel it right here between the shoulders. I have them lift their head and retract their chin. So they lift their head, retract their chin, and then I have them also bring their arms up and squeeze the arms, squeeze the shoulders back. I'm having them, again, it's external rotation. They squeeze those shoulders. They contract for a 10 count, relax, repeat 20 times. I love this exercise too. It is such a humbling and challenging exercise. It's so simple, and it is very effective to correct that specific posture that I showed you guys. Last one, the wall angel. So the wall angel is, like I said, is the one that I give almost every patient. Specifically, it is great for people who have that knuckle dragger posture. He's a good example here. If you know what I mean, is internal rotation of the shoulders. His shoulder is so far internally rotated. What I mean by that, it's like rotated forwards. And like one of those quote unquote knuckle draggers, like if you could see this patient, I should have put his posture from face on. If you're looking at him face on, you see all of the knuckles. So as they're kind of standing, their knuckles face forward. If you're looking at me up in the corner on the screen versus having the hand at a 45. So when they're really internally rotated, you start to see the knuckles face on when you're looking at them in front posture. That's a lot of internal shoulder rounding. So the wall angel is a classic, like it's textbook when you see this type of posture. And then if you see this on x-rays, right, increased thoracic kyphosis with head going forward, that is like a prime example of who should be doing the wall angel. And what you'll find is they are going to struggle. They probably won't even be able to get into position properly to do the exercise. So let's play this video. So the wall angel. Okay, so let's see if we can get to side profile. So first things first, they stand up against the wall. Again, you can't see my feet here, but my feet are approximately 12 inches off the wall. That allows them to push the hips back. I always want 5 points of contact with this exercise. Crucial, okay? The hips or the SI joints are the first point of contact. The second is going to be the shoulder blades, or we'll call it T5. Then we want the back of the skull. Those are my first 3 points of contact. Next step is I have their patients bring their arms up to 90 degrees like this. They keep their arms 90. So it's 90-90. They bring their elbows back and contact the wall. From there, if they can do that, that's already challenging for people with a lot of internal shoulder rotation. They then externally rotate the hands until the fingers touch. Okay. So you can see the points of contact right here. This is perfect. So pelvis, shoulders, elbows, head, fingers, and hands straight specifically. So that's 5 points of contact. If they can do that, awesome. They can proceed to the next step of the exercise, which is where the patient will begin to slide their hands up the wall. So then we have them slide their hands up the wall, slowly and controlled, as high as they can, without losing any of those 5 points of contact. So it's crucial that the contact stays the whole time. You have them slide up, right, as high as they can until they feel like they're going to lose contact. So for me, that's about as high as I go till I lose contact, and then slide back down. So this one is a bit different where I'm not going to hold it for 10 seconds at end range of motion. I want that whole movement to be slow and controlled. You know, maybe every repetition by the time I go up and down is about 5 seconds, right? It's not to be fast, but I don't hold this one for 10 seconds at the top. Okay, so they just slide up and down, but I do have them do the same thing, 2 to 3 sets of 10. Now here I'm explaining, if a patient was really stiff, and this is what you're going to see, they're going to be able to touch their elbows. They won't be able to externally rotate their hands because they're so tight and their shoulders are so internally rotated. So oftentimes what I have them do is I always want the arms to be perpendicular to the ground. So in a sec, you'll saw me pull my elbows off. So now my arm is perpendicular to the ground. So what I have them do, instead of doing a wall angel, I have them do contractions. So I have them hold this position and they're squeezing their shoulder blades backwards. So I tell them to just squeeze, right? And then this is where I'll have them do that 10 count. They count to 10, trying to get all the way back to the wall and then relax. Once they get to the point where they can get all 5 points of contact, then they're allowed to start doing the wall slides up and down, okay? Now, I mentioned in, I guess, the prelude email that probably went out to all the Warrior docs, we're going to talk about how do you implement these in office. Maybe even that is too much for you and you don't have time to show all your patients these exercises. If you're running a very high volume clinic, you know, finding the time to go through even 2 to 3 exercises plus a dinner roll with your patients can be challenging. And sometimes you think, well, you don't want to have to look at all the x-rays and you want it to be simple, seamless, and you don't want to think about it. I highly recommend looking into using Posture Screen with the Webex platform. I don't get paid. I'm not bonused on any of these things. I just promote them to docs because I think they are awesome and wonderful tools for anybody that's in a high volume practice that wants to do corrective care, but doesn't want to have to dissect every case and spend the individual time showing their patients these exercises. So Posture Screen, and I'll show you a video here in a second, but Posture Screen is any posture I showed you had red and green lines. Okay, that's all analyzed by this postural software called Posture Screen. So it analyzes the posture, it finds the spinal deviations based on posture, and then it has, if you sign up for the Webex suite, which is, I think it's $50 a month, it'll prescribe the corrective exercises for you. So here, like this is the patient's posture. Here's just a screenshot of an iPad with it. And then it says web exercise. So it says, okay, they got pelvic translation. So it's giving the pelvic translation exercises, showing that they had forward head posture. It's prescribing Pro-Lordotic. It saw that they've got a rib cage flexion. So it's teaching the patient to shift to the side, right? It's got a head translation. And so basically it shows you 3 sets of 10, how many times a week you want them to do it. And all you have to do is hit send. And basically it ships it off to the patient for you. So let me get a different screen share here and I'll show you the video of this. Where are we here? So let's go to this. So it's as simple as this. Okay, thumbs up, you can see my screen. Good. Okay, so here we go. So I'm going to take the volume off. So back again, you know, this is the screen that comes up. You have the posture pictures and it's small icons, so it's maybe hard to see, but this is Dr. Ferrantelli, the inventor of Posture Screen, explaining how it's done. You know, you got the red lines, green lines, the software analyzes the patient's posture. It realizes like here, okay, she's got forward head posture. So it's going to recommend head retraction, Pro-Lordotic, and dinner roll, right? Then all you got to do is basically at this point, it's going to take you to the next screen here where it says send web exercises. You have the patient's email in the iPad. You click send web exercises. It gives you a choice here on this screen. You'll see in a second, he's going to scroll over and hit send exercises. Boom. The patient gets a perfect video sequence explaining to them exactly how to do every single exercise with their rep scheme and so on and so forth. So that way you don't have to spend time doing this in office if you're trying to build that high volume practice. So it's up to you if you want to go down that route, but I think it's a wonderful tool for people that are running that kind of practice. And then I think there's one more screen for you guys. Let's go back to my screen share here. Okay, so that was it in terms of exercises, but just to recap, the 4 that we showed you: Pro-Lordotic neck exerciser, adding that flip movement when necessary, the Titanic, the prone thoracic extension, and the wall angel. As I mentioned, all of those exercises are done 2 to 3 sets of 10 with a 10-second contraction. The only exception is the wall angel, where it's more of, call it a 10-second slide versus contraction. And the exercises are not exclusive. They can be combined as needed, right? Like I might give someone the wall angel and the Pro-Lordotic, or the wall angel and Titanic, or wall angel and prone thoracic extension. You can combine them as you see fit. But as I mentioned, every single one of my patients doing corrective care will get a minimum of 1, if not 2 of those exercises. Lastly, as always, as a thank you, I appreciate so much the opportunity to be able to share this information with everybody. There's a coupon code there, WQ421. It's good from 2 weeks from today. So that's for any dental, Pro-Lordotic, any type of purchases that you guys want from the Spinal Health store. My contact info is there for cases. And then again, my YouTube page, where I've recently added all those extra videos. And then one last note, next weekend, I know there's already a few of the Warriors signed up. I'm doing an intensive dental webinar. It's 12 hours, 6 hours Saturday, 6 hours Sunday. It's going into significant depth about using dental rolls, cases, pre-post, all that fun stuff. So I know there's already quite a few Warrior Docs signed up, but for those of you who haven't heard about it, you have until Friday to register. I'd love to have you guys join me on that. So open it up. Let's hopefully get some questions from docs.
I got a question to start.
Yes, sir, Yuri.
So I wonder if this is what I do with patients is kind of explain the kind of the passive and active components. So they kind of know that there's 2. So the passive is, for the anterior longitudinal ligament, it's the creep effect. And then the active exercises are more to engage the muscles.
Exactly.
So in your experience, so even the wall angel, for example, if people are, like most of our normal patients are deconditioned, they've had this anterior shoulder internal rotation. A lot of them already have some capsular issues in the shoulder. And so they can't even get to that, wall angel position.
Yes.
Do you find that, is there another way to modify that for people that can't really get their shoulders up even to 90 degrees?
Yes, that's a great question. And I don't know if you can see me in my screen if I'm big enough, but instead, if patients can't go here, and oftentimes the problem is it's the abduction, and then you start getting into the internal rotation. That's the position that really kills them. And so what I have them do then is they stand against the wall, they get into that same position, Yuri, and they go elbows straight. So it probably really more like a wall angel. I have them keep their arms down, so they definitely don't break 90 degrees. The elbows are straight, they're still externally rotated, and then they keep contact, and then I just have them slide up the wall like this until it might cause shoulder pain. If they can go all the way up here, great. But if it's just this, they go here, pause, it hurts, and then back down. So those patients who have capsular issues, shoulder pain, typically if they can start at a 45 below horizon, elbows straight, there's no pain or very little pain there, and then they can do a slide straight arm up the wall up until the point where they get discomfort. I tell them to stop there and then go back down. And then obviously as the shoulder rehabs, the spine gets better, they feel better, we try to progress it and make it more challenging thereafter. But that's a great question, because yes, there's quite a few patients who have to start like that.
Okay, and part B of that, what about your lumbar, like your core exercises?
Yeah, so the core exercises that I give people, it varies, but I keep it super simple, Yuri. We have a PDF that we give them for core and not necessarily posture. So I always tell patients there's 3 different kinds of exercises. I tell them there are corrective spinal exercises, which exactly as you mentioned, when I explain sort of the 3-legged stool, that the adjustments are for just overall spinal health, the neurology, stimulating the brain. I talk about the traction is a passive stretch to remold ligaments. The active exercises are to address the muscles and tendons to then be able to hold that new position. So I say there's postural exercise. Then there are core exercises, where core is a form of posture, but it's really more of preventative health. It's spinal strength. And then there are exercises like high intensity interval training, cardio, which is just general cardiovascular, general overall health. And I tell patients, just like you need exercise adjustment traction, you ideally need a combination of all 3 of those exercises to really express your optimal health. So I teach them their corrective exercises, and then I give them 2 basic core exercises, maybe 3. I always do the cat-cow, I do a plank, and I do a bird dog. I try to get, an exercise that has spinal flexion extension, which is the cat-cow. And it's actually really good for the abdominals. There's probably nothing that'll build someone's core better than cat-cow. Plank, because it's like perfect posture and side profile, and they try and hold it. And then bird dog, because it's a cross crawl pattern where they're moving and trying to create stability. But that's virtually all I give my patients for core, because I don't want to overwhelm them. What I've found, Yuri, over the course of time is the more I give them, the less they do. So I try to give, 1 or 2 postural corrective exercises with their Deneroll, and I give them a PDF with those, like a PDF handout of those 3 core exercises. And I say, do these 3 times a week, and you don't have to do this every day. This would be more like part of your gym routine. You do your spinal stability exercises prior to engaging in your, cardiovascular or strength training. So cat-cow, bird dog, and plank. Those are my 3 go-to core.
Okay. I love the dead bug as well.
Yeah, and that's the bird dog, but on the back. So it depends on the patient. If there's pain, like if they're deconditioned, maybe they're overweight, they have a hard time being on their back rolling over, I'll do the bird dog. I like the dead bug personally myself. I find it more challenging. And the bird dog, it depends. If the patient's got knee pain or wrist pain, they can't do the bird dog, I'll flip them over and do the dead bug. But for all intents and purposes, it's very similar. It's a cross crawl pattern where they're trying to create stability with movement.
Okay, last question.
Yes.
Is there any research showing that patients that are conditioned get better results with postural correction? Like for example, your community that they're already doing HIIT exercises, they're already doing their abdominal work, because I just find that the patients that are seen to be the most deconditioned are the hardest to correct. Would that be accurate?
That's tough. Actually, there's a couple of the research projects that are coming out now are like, there's one that Dr. D did. We discussed it this year a little bit, the one that they were looking at the correction in the athletes. And what they found was, I don't want to say the correction was better in the athletes. What they found was the more deconditioned the person, they could actually, the more deconditioned would be, the worse their spinal health. Not necessarily condition in terms of, they haven't looked at like cardiovascular markers to say, okay, cardiovascular strength markers and spinal breakdown or corrective ability from there. What they have identified though is just the more deconditioned you are, I think in terms of like core spinal health, the worse your x-rays are, the worse all of the markers that they measure. So stability, like when they looked at stability, when they look at repositioning, so all the proprioceptive senses are off. And so those patients are going to have a harder time. I think they're going to take longer than an athlete because it's going to take a longer time for their nervous system, for their proprioception, for everything to improve to get to the point where they could get results. But no one has looked at health status specifically in terms of like if they were to take markers like, I don't know what it would be, maybe like a plank hold, a back squat, a mile run, and then look at that compared to deconditioned patients and do like a 3-month trial of corrective care. It would be a super cool project to do. Look at athletes, look at people who are deconditioned, pre-post, who gets better results. No one has done that. If I understood your question correctly, that's more or less what you're asking. Yeah.
Yeah, and my point being that if you're looking at an athlete doing a front squat, they're engaging pretty well all the muscles that they need in order to maintain proper posture as well. So it's, if you're looking at the bottom of a front squat, they're engaging all their posterior core, and the head's back, shoulders are back, lumbar curve is in place. So just, I'm not going to tell regular patients to start doing front squat, but that's the point, I think, is that it just seems like intuitive that would work.
And I think the reality is, if I think about any of the athletes I work with, specific like scoliosis corrective exercises, super tough, takes a ton of coordination of neuromuscular recruitment. And if I get dancers, ballet dancers, gymnasts, they catch on to the exercises in seconds. I get a deconditioned teenager who sits around and doesn't do anything. It might take me 4 or 5 sessions before they can figure out how to do the exercise properly. Things like the Pro-Lordotic and these exercises, when they're athletes, they catch on super quick. So if you think about it in those terms, they're more likely to do the corrective exercises and things properly. So yeah, I would say they are more likely to get better results. One, because they're probably more compliant. They enjoy exercising. They're going to do the exercises and they're going to do them right. But it's a cool project, Yuri, to be done in the future.
Okay, thank you.
You're welcome.
I'll queue people up for you.
I have
Yeah.
a couple of questions.
Yeah, Aaron,
For
go ahead.
sure. Hi, Dr. McLaughlin.
Hi, thank you, Pascal. Dr. Pascal, this has been really quite a very helpful webinar. I'm really enjoying
Cool.
it. Two questions. The first one about the Pro-Lordotic.
Yes.
And I'm thinking of a few patients who have trouble using the cervical dental. They get a bit nauseous and therefore they just don't really stick with using it at home.
Yes.
And would you say, like, do you see as good of a change if they aren't using the dental, but they are using the Pro-Lordotic, because that one doesn't bother them as much? Like if they're super consistent with that, will we get the same results?
That's a great question. And I think the same thing, like I just mentioned to Yuri, no one's actually done that study. And I should be writing these down, actually. And I think I will write these down, because that's a great study to be done. Now, the hard part is getting the funding to someone to do it large scale, Dr. McLaughlin. So no one's actually looked at someone doing Pro-Lordotic versus just dental. I'll tell you from my clinical experience, I've had patients just like you who have not been able to do the dental, who get nauseous, and they do Pro-Lordotic only, and they get good results. They get great results even. But can I say reasonably that it's as good as doing a dental? I can't, because I haven't actually taken the time to look at data, comparing angles, measurements, and so on and so forth. Can you expect to get change if they do the Pro-Lordotic consistently? The answer is yes. And I have quite a few cases where, just as I explained, because I have people do this in the office, if they don't do their dental roll at home, and they'll tell me sometimes honestly, like, hey doc, I haven't done my dental roll really, at all. And they do this consistently 3 times a week, and we'll still get 10, 15 degrees of curve change, at their first re-x-ray follow-up, where we check them at 3 months to see what the correction looks like. So can you expect change just Pro-Lordotic, no dental roll? The answer is yes. Can I say it's as good as doing the dental roll or the combination of both? I don't have an answer for that. And just specifically the exercise to the dental roll, it's going to probably depend on the patient, but you can absolutely expect to see change if they can't tolerate the dental roll, if they do this consistently.
And even when they do have, say, like some early degenerative disc disease in the mid to lower neck, they should still be using it. So that's good. That's really helpful.
Even more so, because the Pro-Lordotic is great for actually getting motion into those joints, right?
Okay. And second part, for the cervical dental roll, for patients, like if they're using a large and they're flexible and their head is all the way touching the floor, like resting on the floor, I know we can add in something thin underneath, but we don't want to push them further forward. So do you tell them to go at the edge of the stairs and let their head hang over, or how do you approach that?
Absolutely. And that ties in almost perfectly to your previous question about like talking about using the Pro-Lordotic. That's a perfect case where you'd want to use a Pro-Lordotic.
Okay.
Why? Because if a patient is that flexible, okay, yes, they can hang their head, and yes, that might add some ligament creep, and that's what I try to get my patients to do. But oftentimes, if they're that flexible, they have a ton of elastin. They have a ton of yellow ligaments. They're very flexible. And so getting creep and getting change with patients who are flexible in traction is super, super, super tough. A case like that specifically might actually get better results Pro-Lordotic only versus dental roll. Now, if you have them doing the dental roll already, and they're not going to hang their head over a stair, or even if they are hanging the head over the stair, start using the Pro-Lordotic, because now you're not only getting some traction, you're getting their head back, but you're strengthening those muscles to hold any bit of change that you can get from that flexible neck. So they are the ones who need Pro-Lordotic the most, are those very flexible patients who kind of lay on the dental roll and go, oh yeah, I could go to sleep on this. They need a Pro-Lordotic.
Okay, that's awesome. Thank you very much.
You're welcome.
Okay, Stephen Lippett.
Hey, Dr. Lippett.
Hi, sorry, I just tapped something by accident.
No problem.
I have a couple questions, but one of them depends on, do you use the Webex stuff yourself?
I used it for a long time, and then I found that I liked showing people in person. I found I had a higher compliance with people doing it in person. And so it's just the way that we've structured it. But I used that WebEx platform for a very long time. And I've considered going back to it for the time savings. So it's hard to say if one is better than the other. I like teaching people for compliance, but I have used it a lot and I love it. It is so simple.
Okay, and so part of my reason was I have been trying to integrate that over the past year.
Okay.
With some success. One of our challenges was that in our office, not all the patients actually get the email because it doesn't come directly from us. It comes from Webex, and so we have to educate them. And anyway, so some patients just I found had a hard time taking enough steps to get to the exercises. So that's one reason I was curious if you had that challenge. But my follow-up question more was in Webex, I found you can only set like 12 weeks programs at the maximum. So do you have a process where you're reevaluating how they're doing their exercises along the way and changing recommendations? Or do you end up, for many chronic postural cases, just saying, keep doing even after it says you're done, and just use that as a way to learn them?
So great question. So if it's 12 weeks and it resets, usually what I'll do is, especially if the patient is doing them and they're using the videos, Dr. Lippett, what I always found is they came back to me and said, hey, doc, I can't get access to my exercises anymore. Can you send them to me? So that was always a great way for me to resend it to them. And those are the patients I knew were doing those exercises. So that is a downfall to WebEx. You got to stay on top of it. And yes, you do have to educate them on the front end. What I had done was I would just create like a template email saying, after their review of x-rays, there was like a template email that we would sort of send to every patient after their review of findings saying, this is what you're going to expect in like a stepwise fashion, just reiterating some of the things I told them in the doctor's report. And so that would be one of them, like you're going to get this exercise, blah, blah, blah. So pre-framing it would always help. Do I change exercises? Always. I always change exercises when I reevaluate. When I reevaluate, not posture, but x-rays. I always recommend exercises based on posture. Now, off of their x-rays. If their x-rays have improved, they have the same problems and they need more, I tell them keep doing the same thing. Let's say, they had that slouchy posture and now all of a sudden I re-x-ray and, like a Titanic example, they're bang on the line. I'm not going to tell them to keep doing the Titanic. I'll tell them maybe now you don't need to do this postural corrective exercise. Why don't you just start doing planks and your core exercises to stabilize it as opposed to correcting it? So I will remove or add exercises as needed, but that is always based on what do the x-rays look like. 80% of the time, the patients keep doing the same stuff because there's always some lingering component, and most of them will never be compliant enough to fully fix a problem. And those that do fully fix the problem, I will change, add, remove as needed, but only at re-x-rays.
Okay, great. Thank you.
You're very welcome.
Okay, Mark, go ahead.
Pascal, this is fantastic.
Thank you, Mark.
We've implemented a lot of your changes from over a year ago, I think. And one is the Pro-Lordotic band. We have all our clients doing it now for the first 3 months.
Yep.
And we've had way better changes on x-ray because of that.
Awesome.
And they love it. And some of them asked to buy them and bring them home.
Perfect.
So we sell them out for those people.
Yep.
But the question is, we have some clients that once they feel better, they seem to get demotivated. And so we always go mobility exercises first, Pro-Lordotic band, then we start general, and then we go to strength training. So, but we find that if they're not doing the basic, we don't keep progressing through all the homework. So any tips on yourself on how far do you push people? I know that you said you only give 2 or 3. There's a fine line between having them compliant versus overwhelming them, and then they just stop everything. So any tips on that part?
That's a great one. I mean, I think what I do is I often ask my patients flat out, Mark, at their re-exam. So at their re-exams, I always ask them every single re-examination, whether it's posture, whether it's x-rays, are you doing your exercises? Yeah. Okay, great. What does that mean? Is it once a week? Is it once a month? Is it twice daily? I want to know from them honestly. And I tell them, like, listen, I'm not here to judge you. I'm here to coach you, right? I'm coaching you through how to become have a better spine, better health. So I get them to sort of tell me really what they're doing, Mark. And like, if they're at once a week doing their things marginally, well, I'm definitely not going to give them any more or try and progress them. I'm going to say, what is it going to take for us to get to twice a week? Or what can I do to help you start doing your exercises 3 times a week? And so anybody that's struggling, it's just, for me, it's always like, listen, I'm not here to criticize you, but the less you do, the more you're going to have to come in for adjustments. So I also try and incentivize them on saying, once you're doing your exercises more, we can decrease your adjustment frequency because your spine is going to be more stable. You're going to hold your adjustments longer. So that's one step. And then two is, if they are keeners and like, yeah, doc, I'm doing this all the way and I want more, and I know they want more, then I'll give them another 2 exercises, Mark, and I'll say, can you handle more than this? Do you want to handle more than this? And the patients who say, yeah, give me more, I'll give them as much as they're willing to take. And so I play it like on a person-to-person basis, and I ask them from an honest perspective, like, do you want more? Do you not want more? And how are you doing? So it's hard. I don't really have any tips other than having an honest conversation with them.
That's great. And can I also ask one more quick one? I noticed you're doing stress x-rays with the Pro-Lordotic band.
Yeah.
Is that what are your parameters on when you'll do a stress x-ray with a Pro-Lordotic band?
That's a good question. I don't know if I have an answer for that, Mark. I see my x-rays, I see patients coming in, and I look at something and I'm like, oh, I want to see what this looks like. And I do it for me, for like education. I just think like, wow, like I think this young lady, the reason I did this is she was doing a posture regainer at home. And, you know, she almost looked a little bit hyperkyphotic, and I wasn't sure if I would do a Pro-Lordotic, but I take a re-x-ray and I'm like, whoa, your neck hasn't really changed. You're still 43 millimeters forward. It's one of those examples where I think you're super flexible. Well, let's just see what your neck looks like if you do the Pro-Lordotic. So I give it to her and say, okay, do this now. And I just retake the stress film, or those x-rays where I see like a kyphosis in the neck. And I wonder, you know, is it going to change? And I take stress x-rays based on, if I don't see the results that I'm looking for, I'll take a stress x-ray of something new so that I can modify the patient's recommendations. If they're starting care and I want to see how they might respond to something, and I want to increase my clinical confidence of the down roll working or this exercise working, I'll do the stress x-ray on like day 3 to make sure that I'm going to recommend the appropriate stuff for them. So I don't really have an indication. I just follow my gut, really.
Thanks so much.
You're welcome.
Okay, we got one more, Bernadette.
Hi, Bernadette.
Hi, Dr. Pascal. Thank you.
My pleasure.
I have 2 questions. One of them follows Mark's about
Okay.
the stress x-ray.
Yep.
What do you say to somebody? I've never taken stress x-rays, so like,
Yep.
what's your script? What's your sentence? How do you go about saying, this is why I want to take another x-ray right away?
Oftentimes if it's at the beginning of care, I will tell them like, listen, you know, I've just finished going through x-rays with them, right? We've done the doctor's report. I've gone through x-rays, and I'll tell them like, listen, this, obviously there's phase 1 damage, phase 2 damage. I'm concerned about this. There's instability here. Oftentimes I'll tell them, especially like, let me go to this next x-ray, you know, like this is kyphotic, right? This one's not bad enough that it's unstable, but I look at this and I'm like, okay, well, I don't know how this is going to respond to, maybe just a Pro-Lordotic or head retraction. And I want to see something. I want to know how the patient is going to respond to their home recommendations. Oftentimes I tell them it's for them. I want to do this specific film to see how your spine is going to respond to the home exercises and the traction that I'm going to give you, so that we know you're going to get the right result. And so I tell them I'm doing a little bit more research so that they get a better result. That's what I tell them. Or if it's an example where I've done a re-x-ray and I see, even without measuring their pre-post x-rays, I took the x-ray of that young lady like that one, and I could tell right away, I'm like, okay, something's not working here. And so I'll just say, hey, listen, I want to test something because this is not the result I was expecting. And I'll just be flat out honest. Like, either you're not doing this or it's not effective enough. We need more. And so I'll just grab the Pro-Lordotic, give it to her and say, do this exercise, and then re-snap the x-ray. So again, I think for me, a lot of it comes from just being completely honest with them, saying, I want to do this, so I know I'm giving you the best exercise, or, hey, either you're not doing your exercises properly or we need more because I think we could do better. That's basically how I approach it.
That's good. Thank you. And the other question I had was regarding the wall angel position.
Yep.
I often give that exercise, but I have, you said keep your feet like 12 inches from the wall.
Yep.
Like, is there a reason you do that? I often say keep them as close to the walls, take them away from the wall if you need to for comfort. Yeah.
It's balance. You know, I think so many people, have you ever tried it? Bernadette,
Yeah.
Have you tried both?
I haven't really done I've done both. I try to keep my feet as close to the wall as possible. Yeah.
what feet against the wall is significantly harder. And so if you've got someone who's flexible and they could do it and they slide the whole way up and it's not even a challenge for them, bring their feet back. Most people are so deconditioned, I find it's challenging enough that if they keep their feet off the wall, they're allowed to, like, they can use their legs and their feet to sort of maintain a posterior pressure. And so it allows them to not worry about falling off the wall, but they can focus on the actual movement, contraction of the muscles in the upper thoracic and cervical spine, where if the feet are touching the wall, oftentimes like you're, doing that motion is like sending you forward, and it becomes more of a proprioceptive balance exercise. So I have them keep their feet off the wall so that they can focus on the exercise up top. But then also in a lot of those cases, I find patients, if they're hyperkyphotic, they also have a hyperlordosis, right? They've got too much lumbar curve. And so if their feet are off the wall, it also gives me the opportunity to sort of cue them and say, now do a hollow. So suck your belly button in and try and flatten your low back. If their feet are touching the wall, that's going to be next to impossible for someone with too much low back curve. So that's the main reason I do it. But it's not wrong to do it the other way. It's just much harder with the feet against the wall from my experience.
Thank you. Sorry, my dog was barking, so I had to unmute myself.
That's all
Thank
good.
you.
All good. You're welcome.
I guess we have one more follow-up from Aaron.
Okay.
This is really quick. Do you charge the patient for all the stress films?
Well, one, if a patient's like, if we have someone that comes in and wants to do like a couple of adjustments to not follow through with care recommendations, I will never do a stress film because they're not committed. They're not doing corrective care. So once a patient commits to doing care and they're all in and they're on a care plan, no, then that's part of the reason, like we tell patients, you do a care plan, we give them the dental rolls. We don't charge them for the dental rolls. We don't charge them to show them these exercises. We don't charge them for stress films. That becomes all inclusive in the care plan. So
Yeah,
no, I don't charge it for them.
That's how we do it too. Like we don't charge the patient for it. It's just kind of built into like what they're doing. But I was just curious. But thank you.
Yeah. Okay, well, I think that's going to be it. All I have time to, because I'm going to have a patient showing up here any second. So I guess we'll wrap it up from there. But great questions. Thank you very much. And once again, to everybody from Warrior, thank you for having me. Dr. Yuri or Dr. Ed, anything else to add?
No, it was awesome. So thanks for all the input, and guys, just go do what he's teaching you. So thanks, Dr. Pascal.
See you in 2022.